So it's again a very good integrated question. Let's see this. This is a 3-year-old child who is coming with a 7-day history of fever of unknown etiology. We have bilateral conjunctival injection. We have polymorphous rash, erythema, edema of the palms and soles are there. Periungual desquamation is there. Lymphadenopathy is there. Injected pharynx, tongue, and even the fissuring on the lips is also there. And eye may we have mild bilateral anterior uveitis. So which study should be most appropriate? First of all, can you tell me the diagnosis? This is a question related to the pediatrics, and they are lending up in medicine, and Mage may they are also telling the ophthalmology, hai na? This is the ophtha part, this is your pediatrics part, and they are asking you the medicinal part. So yes, can you tell me the diagnosis here? Let us see. 10 seconds. What is the diagnosis here? I know this much that maybe you will not get the exact questions in the examination because I am not making the paper. But definitely the question that will come will touch these. So can you answer this? Okay. Deepthi and Harika Berry. Correct. What about the others? So what is this disease? What is this Kawasaki disease? So I think it's a very important disease that you people are studying in the pediatrics, where you are having the vasculitis, right? So if you look here, we have involvement all over. So it's involving the general systemic, starting with the fever is also there. Then we have the cervical lymph nodes enlargement. In the eyes also, we can have conjunctivitis, we can have uveitis, we can have colobomas, and a vasculitis may, the coronary artery are involved very, very severely, and that is why we are worrying actually. Then can you tell me what is this? A very typical feature that you get in cases of this Kawasaki disease. Can you tell me this? I think it's a very beautiful picture, and beautiful in the sense that you have the typical appearance. So very easily you can tell this, what is this? So even sometimes instead of giving the whole picture, they can give you this and they can ask you. So what is this? Yes? Anybody? So Kawasaki disease is involving the skin also, it's involving the mucous membranes, and then it's also involving your coronary arteries. So I'm worried about coronary arteries, right? So what is the thing that I can do? Yes, it is a strawberry tongue. Very correct. It is actually the very typical strawberry tongue that you are getting here. So basically, when I am worried about the vasculitis, what should I do? Should I do the ECG or echocardiography? Will I do chest radiograph or HLA-P27 for that? No. I am worried about vasculitis. Vasculitis may I will do the echocardiography. For what I am going to do? In order to see the ventricular function. What is the level of the ventricular function, or if there is any collection of the fluid, I will have to see that also. And then I will also have to see if there is any coronary artery aneurysm. If there is any coronary artery aneurysm. So to see the functions of the ventricles, if there is any collection of the fluid, or I have the coronary artery aneurysm, I will do the 2D echocardiography. Right? So please remember this. Again, a very important integrated question, and definitely, yes, I have tried to take the systemic approach of the topics, because over the years I have seen that AIMS people are interested more in the systemic aspect of the diseases. And if you look at the previous paper, INICT 2020 paper also, they had asked almost all the questions were about the systemic aspect. So this is what I did. I did the thorough, while there were only I think 6 or 7 questions of ophthalmology, but I have gone through them And after proper research, I came to this conclusion that they are asking about the systemic involvement. That is why I am taking about these systemic things, right? All right. So let us see another question here. Again, we have an infant girl is there, and she is 4 weeks premature. Okay, she's 4 weeks premature, and she's presenting with jaundice. We have a rash, we have rhinitis, pneumonia, anemia is also there. We have generalized lymphadenopathy, lymph node enlargement is there. Bony abnormalities are also there. So on the ophthalmic examination, what are you expecting? So can you tell me the diagnosis? See, if you are able to make the diagnosis, then very conveniently you can tell me that what could be our finding here. So infant girl, premature, with jaundice, with rash, with rhinitis, with pneumonia, with anemia. See this. And we also have the lymphadenopathy, and we have the bony abnormalities also. So what should be the diagnosis? They are asking you what will be the ophthalmic examination of this child. This child can come with interstitial keratitis or segmental pigmentation of the periphery, chorioretinitis, or anterior uveitis. So anterior uveitis, chorioretinitis is posterior uveitis, or presenting with interstitial keratitis, or we can have the segmental pigmentation of the retinal periphery. What will be the presentation? So what is the diagnosis first? So they are asking you the diagnosis indirectly, only then you will be able to tell the ophthalmic one. So people are saying answer is interstitial keratitis, syphilis, viral keratitis, congenital syphilis. Yes, so diagnosis is correct. This is a case of a congenital syphilis, right? This is a case of the congenital syphilis. Now, what is the most common presentation of this congenital syphilis? It is actually the segmental pigmentation of the retinal periphery. So, salt and pepper retinitis is a usual presentation. Like interstitial keratitis can also be there, and it is also one of the presentation, but it is not the most common one. The most common presentation that you are going to get is the salt and pepper retinitis. Always remember that in congenital rubella as well as in the congenital syphilis, dono mein hi salt and pepper retinitis are much more common, right? So if you look at this now, these are the babies who are showing the presentation of the congenital syphilis. Now can you see here we have the integration with almost all the topics. So we can also have the hydrophthalamus. So this could be asked as the OBG question. We can have a nasal discharge. So this becomes your ENT. Rash. So this person can be coming with a derma. Then hepatomegaly. So medicine is also there, or pediatrics bhi bol sakte hain. ठीक है ना? Then we have the rashes, again your derma one, and then you also have the bony abnormality. So I think congenital syphilis is again a very important topic for your integration, and ophthalmology is of course there. And see this. So ophthalmology is usually coming late, where you are getting this Hutchinson stride. You are going to get this Hutchinson stride. Hutchinson stride mein, one is your Hutchinson's teeth, and then you are also getting this interstitial keratitis. So interstitial keratitis is a late feature. Interstitial keratitis hai, but it is late and it is not that common. Most common jo hame mil raha hai, that is your salt and pepper retinitis, and then you are also getting the sensorineural deafness. The nerve deafness is also there. Uske saath, of course, you know ki we can have saddle nose, you can have frontal bossing can be there. Joint involvement can be there, so that could be there. But this Hutchinson stride is important. It is important as a cause of the interstitial keratitis also. But the thing that you have to remember is that it is coming as a late involvement and not the early involvement, right? Okay. Yes. Now let us see the important things in the retina, because the question is asked, can you tell me the diagnosis here? Once you will tell this diagnosis, then I will show you a similar picture, and then we will be discussing that how to differentiate between the two, because you will be having the same problem in the examinations. You will not be able to find out that whether it is this or whether it is that, because they look quite similar. So can you tell me what is this? Anybody who can tell? Because we have taken the fundus images many times. We have done a separate video also on fundus images. So what is this, and what is the most common cause of this? Yes. Anybody? I will give you some options. Option number 1 is it retinitis pigmentosa? And number 2, is it salt and pepper retinitis? Is it salt and pepper retinitis? Or is it the angioid streaks? And number 4, is it NPDR? So very good, you people have given almost all the causes of salt and pepper retinitis. So how to get that this is salt and pepper retinitis? Because you are getting the alternate patches of black and white flakes here. That is why it is salt and pepper retinitis. Now why it is not retinitis pigmentosa? Look at this picture. If it is retinitis pigmentosa, then I will have a pale optic disc. I will have the attenuation of the vessels. Attenuation of the vessels is also there. And then I will have these spicules, the pigmentary spicules. So please, whenever you say that it is the retinitis pigmentosa, always look at the typical triad. You should have a pale optic disc, you will have the attenuation of the vessels, and you have the pigmentary spicules also. Only then it is retinitis pigmentosa, all right? Then we will do one more that is again very, very similar. Can you see this? What is this? Can you see these arrows here? So you can see these streaks kind of a thing, very, very thin streaks. This is also very much similar. So what are these streaks? One was retinitis pigmentosa, one was your salt and pepper retinitis, retinopathy, and one is this. Can you tell me this one? Okay, I'll post that. So anybody who can tell the diagnosis here? Yes, very good, Sakshi. So these are actually the angioid streaks. So you should be able to identify. Yes, that is also correct. These are angioid streaks. So where we have the retinitis pigmentosa, where we have salt and pepper retinitis, and where we have these angioid streaks. And do you remember what was the DD of this angioid streaks? The DD. It is actually the Pepsi. It is the Pepsi. That is, we have pseudoxanthoma elasticum. Pseudoxanthoma elasticum is there, right? Then we have another E. This is E for the Ehlers-Danlos syndrome. Then we have this P. This is your Paget's disease, right? Then you have S. S is your sickle cell retinopathy. And then you have I. This is your idiopathic. So these are the things. You can always easily remember it with the help of a Pepsi. We have pseudoxanthoma elasticum, Ehlers-Danlos syndrome, we have Paget's disease, we have sickle cell retinopathy, and we have idiopathic. So these are the causes of angioid streaks. Okay. All right. This I'll come again. We have a question on this. Okay. Now, a easier one. See this. Can you tell me the ocular pathology? Can you tell me what is this? So again, this question consists of two parts. First, you have to identify what it is, and only then you will be able to do that where it is found. So what is this and where it is found? Is it found in the Down syndrome, neurofibromatosis, sarcoidosis, या फिर leprosy? Let me see if you can answer this. This is again an interesting question. Yes. I have posted it, Mariam. Look at the live chat, you will get it. I have posted it. Identify the ocular pathology. So, can you tell me what is this and where it is found? What is the pathology and where it is found? Acha, if I say that in the Down syndrome, we get the brush field spots, okay? And in the neurofibromatosis, we have discussed that we get the lesion nodules. Sarcoidosis mein, I will get the candle wax droppings in the fundus, and in the iris we get what you call as the Koipe nodules. And what do you get in leprosy? We get the iris pearls. Iris pearls appearance are there. So Down syndrome में we have the brush field spots, neurofibromatosis में lesion nodules हैं, sarcoidosis में Koipe nodules हैं, and leprosy में we get the iris pearls. So what are you getting in this case? What is the appearance over the iris in this case actually? Can you now tell me? Is it a brush field spots or are the lesion nodules? I have also already shown you also the lesion nodules. And is it the iris pearls appearance or is it sarcoidosis, Koipe nodules? Now, before I will answer this question, I will also show you. See this. So these are your lesion nodules. That is the iris hematomas. ठीक है. Then see this. Sarcoidosis में we are getting the KPs, which are very, very typical because it is a granulomatous uveitis. So what kind of KPs I will have? The mutton fat KPs. Mutton fat KPs in the sarcoidosis. And a very, very typical finding that you get in fundus is your candle wax droppings. So candle wax droppings mein kya hai? Because you are having the exudation. Is it visible? I will draw with black. Okay. So you are getting these exudates in the fundus cavity. These are your candle wax droppings that you are getting in the fundus because we have vasculitis. So we have inflammation in the peripheral veins of the retina. So if you are having what you call as the retinal periphlebitis, which is leading to the dropping of the exudates in the cavity. So this is actually called as the candle wax droppings in the cavity. So this is again very typical of the sarcoidosis. Then you are getting these keratic precipitates. And if I talk in terms of the iris nodules, so you can get two kind of nodules. One is your Koipe nodules, these ones. These are present just at the pupillary border. So when they are present just at the pupillary border, these are your Koipe nodules. Then these are the Koipe nodules, and when they are present at the mid periphery या फिर they are present at the base इस तरह से, then these are your Busacca nodules. These are the Busacca nodules. So you have seen the Lish nodules also. You have seen the Koipe nodules, Busacca nodules. You have seen the mutton fat KPs, the candle wax dropping. So we are covering many of the images also. Okay? And somebody told me that this is iris pearls. Now see, iris pearls mein kya hoga? They are just at the base. So they are literally at the base. Like this. These are your necklace-like appearance, iris pearls appearance. Is tarah se hai. Necklace-like appearance. So this is your iris pearls. Now, if you look at the picture which is given here, it is not just at the base. This is your base here, and they are somewhere away from there. So these are your, what you call as brush field spots. Because these are the brush field spots, so answer will be Down syndrome. Is it clear now? Yes. Is it visible? Busacca nodules kahan milte hain? Both Busacca nodules as well as the Koipe nodules are found in the granulomatous uveitis. It could be a mixed one also. And like in tuberculosis, you get more of Koipe nodules. Somewhere you can get more of the Busacca nodules too. All right. So are you clear with this? So now you can get a question on Lish nodules, brush field spots, iris pearls, Koipe nodules. You can answer any of them, right? And your people's all-time favorite. What is this? So we always have a lot of confusion in this. So in order to ease you, see, I have given you options related to the proximal optic nerve or the distal optic nerve, and right or left. So you have to just decide, is it a proximal optic nerve lesion or is it a distal optic nerve lesion, and the lesion is towards the left or the right. So first of all, let me see if you can answer, and then obviously I'll explain. See, if I start with the eyeball, so this is your eyeball here, and this is the retina, and we have divided it into two parts. Okay? Now these are your nasal retinas, and this is the temporal retina. Okay? Now in the nasal retina, what is we have the nasal fibers of the optic nerve coming out, which will be crossing over, and towards the temporal side we will have the temporal fibers. Okay? And these will be remaining on its own side like this. Okay? Now these are your nasal fibers. So this is your supranasal fiber, and these are your infranasal fiber which are crossing over. Okay? Now this side we have total optic nerve, nasal bhi hai, temporal bhi hai. Now what happens, these infranasal fibers, when they are actually going and they are decussating, what they are doing, let me show you, they are not coming it directly. So they are actually making a loop. So when they are decussating, they are making a loop here, and then they are decussating like this. This loop is called as the anterior knee of von Willebrand. This is called as the anterior knee of von Willebrand. So this loop is carrying what? This is in itself is the infranasal fibers. It is also carrying this temporal fibers and this nasal fibers. ठीक है ना? So that means opposite side के it is comprising of the infranasal fibers of the contralateral side हो गया, and the total optic nerve. This is the total optic nerve of the ipsilateral side. So if I have some lesion here, suppose let me show you that there is some lesion here. Okay, suppose I have a lesion here. So lesion में ये आ गया. So that means this lesion is going to involve what? This is going to involve the ipsilateral optic nerve fibers, total optic nerve, plus contralateral के it will involve only the infranasal fibers. Contralateral के only infranasal fibers. Now, optic nerve will lead to the total blindness on the side of the lesion, which is called as a central scotoma. So, that is why I will have ipsilateral central scotomas, because optic nerve leads to the central scotoma or the centrocecal scotomas, plus what we have. Now, because I have just the infranasal fibers involvement, and we know that the field which is involved is always diagonally opposite. So other side का क्या हो जाएगा? Supratemporal quadrant enopia. Quadrant enopia. So opposite side का supratemporal quadrant enopia हो गया, ipsilateral का central scotoma. So इसका मतलब whichever side I have central scotoma, that side will be the affected side. So look at the question now. I have, like for example, in this side, right, they are giving you the central scotoma. We have right central scotoma, and we have the left supratemporal quadrant enopia. इसका मतलब which side is affected? Right side is affected. So left का हम दोनों cut कर देंगे. Now we are left with the right proximal या फिर right distal. So what is this? This is your the junction. The junction. So this is present at the junction of the optic nerve with the optic chiasma. This is your junction of the optic nerve and optic chiasma. That is why it is also called as the junctional scotoma. That is why it is also called as junctional scotoma. So you should know what is anterior knee of von Willebrand. What is junctional scotoma? It is a junction of optic nerve and optic chiasma. So because the involvement of the optic nerve is just proximal to the optic chiasma, this will be your proximal optic nerve lesion. So this is called as the proximal optic nerve lesion. And which side? Right. So answer will be what? So my answer will be right proximal optic nerve lesion.